Hello, friends. Welcome back. I'm Dr. Harvinder Singh, and this is our video podcast number 5. And this will be chapter number 201 in our course Physician Guide for Clinical Psychiatry. I have decided to do this podcast on PMDD, which is premenstrual dysphoric disorder. We know that close to 70 to 90% of reproductive age women have either one or more physical or emotional symptoms during luteal phase of the cycle, and close to 20 to 40% have symptom consistent with premenstrual syndrome, pre-PMS. We'll talk about that more in the course. And close to 8% have symptoms severe enough, interfering with their daily functioning. And that's what PMDD is, premenstrual dysphoric disorder. This topic is of direct clinical relevance for psychiatrists. And in this chapter, after reviewing this video podcast, you will be able to diagnose PMDD. You will know how to differentiate PMS from PMDD. You will know what scales to use, how to follow up your patients. You will know what medications are FDA approved for treatment and what non-FDA approved medications have shown efficacy in literature. What dose of medications to use, if daily versus luteal phase dosing is efficacious, and how long does it take for medications to show response in PMDD. And there are many more things you will learn after viewing this podcast. I reviewed many articles in literature, but found close to 26 to be of relevance. Below, you can see all of those references with either PDF or PubMed link to each article. Please let me know if you like this. Without wasting any time, I will start this video podcast. Let's begin our topic for today, premenstrual dysphoric disorder, which is PMDD. Before I start this discussion, just want to summarize the topics that I will be talking today, and there will be 4 main topics that we will discuss here. First is, how do we diagnose PMDD? Second is, how do we differentiate PMDD from premenstrual syndrome, PMS? Third, how do you evaluate PMDD with scales? And fourth, which is the most important, and I think the most part of this podcast, is treatment option for premenstrual dysphoric disorder. And this will focus on not only pharmacologic option but non-pharmacologic options also. So let's discuss first very basic history of PMDD. In 1987, DSM-3 included the criteria for LLPDD, which is late luteal phase dysphoric disorder. We all know that luteal phase begins after ovulation and ends with the start of menstruation. And in DSM-4, the name was changed to PMDD, premenstrual dysphoric disorder. The criteria were almost identical to LLPDD. And in DSM-4, actually, PMDD was I think the example of something called depressive disorder not otherwise specified, NOS. But in DSM-5, we have a full diagnosis here, premenstrual dysphoric disorder. I think the code is 625.4 for premenstrual dysphoric disorder. Now, how do we diagnose PMDD? I will be actually summarizing criteria as mentioned in DSM-5, but I have made some diagrams here to make it more simple for everyone and more easy for everyone to ask these questions from every patient that we suspect having this diagnosis. So, first, how many symptoms are needed? At least 5 symptoms are needed in majority of the menstrual cycles. Now, what time period do we focus on when we ask questions to females? This is the timeline. So, mostly final week before the onset of menses, symptoms should be there, and symptoms should start to improve within a day or two and should not be there within a week post menses. This is a time period that we will focus on with all the symptoms moving forward. Now, what symptoms are we talking about? So DSM-5 actually makes 2 categories here for symptoms. First category symptoms are must. At least one of these symptoms should be present. And then there are some additional symptom categories that may accompany these must category. But what symptoms are included in this must symptom category? So first and most important is marked affective lability. This means a person is having mood swings, feeling suddenly tearful or sad, feeling increased sensitivity to rejection. That's number 1. Number 2 is increased irritability or anger or increased interpersonal conflicts. That's number 2. Number 3 is increased depressed mood, which can be increased feeling of hopelessness or self-negative thoughts. And fourth in this is increased anxiety or tension or feelings of being keyed up or on edge. So these are the 4 symptoms in this class. At least one should be present. More can be present, but at least one of them should be present, not the other way around. And what are the additional symptoms that can be present to make this number total 5 symptoms? In this other class, the first symptom is decreased interest in usual activities like work, hobbies, friends, school. Second symptom here is decreased concentration. This is more subjective symptom. Third is marked lack of energy or feeling lethargy or getting easily fatigued. Fourth symptom here is fluctuation in appetite. That can mean decreased appetite, overeating, or even specific food cravings here. And fifth symptom here is fluctuation in sleep. That can mean insomnia or hypersomnia. And then sixth symptom here is a sense of being overwhelmed or out of control feeling. And last symptom here is physical symptoms. And the physical symptoms most commonly reported are breast pain, tenderness or swelling, muscle or joint pain, sensation of feeling bloated or weight gain here. You must have noticed that most of the symptoms are mood or anxiety symptom, and then in the end we have physical symptoms. We'll talk about the relevance of this in few minutes. So look at this table. We know the timeline that we need to focus on. We know the symptom that we need to ask for and what are the must symptoms here. But there is one more thing we need to ask, which is symptoms are present, but these symptoms should be confirmed by at least 2 prospective cycle. So when a patient comes to you, you suspect PMDD on your first visit, you have to follow this person for at least 2 prospective cycles, having these symptoms in next 2 cycles. And we will talk about the process for that. How can we do that? So this is how you diagnose PMDD. Now, main difference between PMS and PMDD, I won't spend much time on it, but just to cover every topic in this podcast, let me go back to what I did with PMDD diagnosis. Look at this table. I circle the physical symptoms here. I'll tell you why I did that. So, and look at the blue here, the 2 prospective cycle box that I have. So the main difference between PMDD and PMS is, first, definitely PMDD's more severe symptoms affecting daily functioning, whereas PMS severity is not that high. And also PMDD diagnosis was given is in the American APA diagnostic criteria, whereas PMS diagnosis is given by ACOG. I think that's American College of Obstetrics and Gynecology. But this is what PMS diagnosis is given by them. Take a pause, look at it. First difference you will see is they have 1 affective symptom and 1 somatic symptoms. Timeline is almost same. Symptoms are almost same, but to a less degree. Look at the blue box there. 3 previous cycles should be present. So looks like PMS looks at the retrospective way. 3 previous cycle with same symptom, 1 affective symptom, 1 somatic symptom, you have the diagnosis of PMS. Whereas PMDD is more prospective diagnosis. Symptom severity is more and the symptom number is more. So PMDD is more intense diagnosis and more difficult to meet criteria for. Now, this is the main difference between PMDD and PMS. Now, so you have a patient, you diagnose them with PMDD. Before we move forward, I just want to say one thing, that once you have a diagnosis of PMDD on a first visit, you can give them a specifier. Like you can diagnose them with PMDD with a specifier of provisional there, which is a provisional diagnosis. You have to measure these symptoms in next 2 prospective cycles, and then you can give them confirmed diagnosis of PMDD. But how will you confirm these symptoms? Most effective way of doing that is by utilizing scales. So prospective questionnaires are the most accurate way to diagnose PMDD. And there are many scales. The first one is DRSP, Daily Record of Severity of Problems. Second is DSR, which is Penn Daily Symptom Rating. Third is MDQ, which is Menstrual Distress Questionnaire. In this podcast, I will only briefly summarize the first one, DRSP, which is Daily Record of Severity of Problem. Now, here, this scale in this patient will be tracking their symptom from day 1 to day 30 of the month. Each day, they can track each symptom that we talked about. Now, you see this link that I have mentioned here? I want everyone to please take a pause here. I have placed this link below this video in the course chapter. Please click on it. This is the PDF of this scale from AAFP website. Because of copyright issues, I have not placed the table here, but please look at the table. Very beneficial table, very easy for patient to understand. Each day they can mark each symptom that we talked about, both mood symptoms, anxiety symptoms, and somatic symptoms. In these, patients will give numbers or ranking to each symptoms. And it's rated from 1 to 6, 1 being no symptoms and 6 being extreme symptoms. And then you count all the numbers, and if the score is less than 50, then the diagnosis of premenstrual syndrome is less likely. And if symptom is more than 50, then you have to record 2 cycles to give somebody diagnosis of PMDD. Again, please review that PDF link that I have placed downstairs. Very helpful scale, and just doing 2 prospective cycles will give you the diagnosis. So you have done the DSM criterias, did the 2 prospective scale monitoring, and you have diagnosed your patient with PMDD. Let's begin the most important section of this podcast, which is treatment. Before I go into the medication options, let's briefly discuss what studies have shown us in terms of effect of lifestyle modification with these symptoms management. First is aerobic exercise. Well, there are studies which shows that in late luteal phase, there is a decline in endorphin levels, which can contribute to these symptoms, especially the premenstrual symptoms in some women. And this study shows that a regular aerobic exercise can increase the release of endorphins. And they recommended that if a woman perform at least 20 to 30 minutes of aerobic exercise each day for at least 3 days a week, beneficial effects will be seen in premenstrual symptoms. That's number 1, no side effects. Number 2 is reducing caffeine and alcohol intake. And a few studies have shown how premenstrual symptoms get worse with caffeine, with alcohol, and even with salt intake. That's number 2. If possible, reducing caffeine intake, avoiding alcohol, more benefits of that. Now, number 3, other than exercise and avoiding food, calcium supplementation. Now, this is very interesting. So, studies have shown effectiveness of calcium in moderate to severe premenstrual symptoms. And there was this study where they randomized people to 1200 milligram per day of calcium carbonate and placebo for 3 cycles. And what did they found? They found that premenstrual symptoms were significantly reduced in the calcium treated group, especially on 2nd and 3rd treatment cycle. So this is worth an option for management of premenstrual symptoms. That's number 3. Number 4 is supplementation of magnesium. Magnesium, there was one study that I found. It was a double-blind, placebo-controlled crossover study. Here, women were randomized to 200 milligram per day of magnesium or placebo. What did they found? Well, they found that women who received daily magnesium supplementation had a significantly lower symptoms of fluid retention, which is, you remember that table that I showed you? Physical symptoms, weight gain, breast tenderness, swelling of extremities, abdominal bloating. And this was actually noticed by the second cycle of treatment. So worth an option, 200 milligram per day of magnesium. Fifth one is vitamin B6. And there was one study that showed this 50 to 100 milligram per day range can be beneficial in reducing the symptoms, but be mindful here. If you increase the dose beyond 100 milligram per day, it can be harmful. So staying below 100 is an option if you decide to use vitamin B6. Now, these are the non-pharmacologic option: aerobic exercise, reducing alcohol, caffeine, considering supplementation with either calcium, magnesium, or vitamin B6. So you have decided to initiate medications. I will recommend initiating with antidepressants first. Most data is on this class of medications. At this time, there are 3 FDA-approved medications, antidepressants. First is Fluoxetine, second is Sertraline, and third is Paroxetine. Next few minutes, I will describe these medications individually, but with focus on randomized controlled trials only. And we will try to see if we can learn something clinically relevant for our daily practice. Let's start with Fluoxetine. So first question is, what dose of Fluoxetine is found effective for physical symptoms and mood symptoms in PMDD? To answer this question, we will see this study done by Cohen, published in 2002. And here they randomized a woman to Fluoxetine 10 milligram, Fluoxetine 20 milligram, or placebo. And when was this medication given? This was actually given only during luteal phase, which is medications were started 14 days before next expected menses, and they were continued through first full day of bleeding. And this was done for 3 cycles. And the scales that they used was DRSP that we just talked about, daily record of severity of problem. And the result was very interesting. So first they found 20 milligram of premenstrual dose of Fluoxetine was significantly showing improvement in DRSP luteal score compared to placebo. So 20 milligram was effective. But 10 milligram was not statistically significant dose. Very important finding here. And as expected, Fluoxetine group, both dosing, showed effect on mood-related symptoms. But what's interesting is this. Only 20 milligram dosing showed effectiveness for physical symptoms, which is breast tenderness, bloating feeling, joint or muscle pain. And in terms of side effect, this treatment was very well tolerated. Side effect wise, in terms of discontinuation due to adverse effect, it did not differ among all the 3 groups that we talked about. So, lesson from this study is 20 milligram is effective for both mood and physical symptom. 10 milligram not so much for physical symptoms here. Now, how about higher doses of Fluoxetine, more than 20 milligram? Is that effective for PMDD symptoms? To answer this question, I will briefly summarize this study done by Steiner, published in 1995, and this was also a randomized double-blind placebo-controlled trial. And here The women received fluoxetine 20 milligram and 60 milligram per day. But these were actually done on a daily basis, not only on the luteal phase. So it was a daily dosing done for 6 cycles. And they used a different scale here, VAS, which is Visual Analog Scale, with focus on tension, irritability, and dysphoria scales. There were 3 scales. What did they found? Well, 20 milligram or 60 milligram, they both were superior to placebo in terms of reducing all the 3 symptom scales: tension, irritability, and dysphoria. But there was one big difference between them, and that was the side effect. 60 milligram had significantly more side effect than the 20 milligram one. So you can definitely go beyond 20 milligram, go to even 60 milligram. I was not able to find study for 40 milligram, but side effect profile will increase. We know this from our fluoxetine use in major depressive disorder class. Next question is, well, how long does it take for PMDD symptoms to improve with SSRI? Let's say fluoxetine here. Does it take 4 to 6 weeks like it takes for antidepressant response? Or will you see response in less than a week? This was very interesting question for me when I started reviewing data on PMDD. Well, this will be answered by study done by Steinberg, published in 2012. Here, they did an hourly rating in women with PMDD after they received fluoxetine 20 milligram, but again, only during luteal phase. It's like an intermittent dosing. They use this term intermittent dosing in the literature for luteal phase dosing of medications. And the scale they used was visual analog scale that we saw in last study, and this other scale called PMTS, which is Premenstrual Tension Syndrome Scale. What did this study found? Well, symptom improved within 48 hours after starting treatment in 2 days. Amazing. And all symptoms improved, not just one: irritability, sadness, anxiety, and mood symptoms. And the average time it took to achieve a clinical response was 1 to 6 days. This information is very important when you tell patients about importance of these medications and what to look for in terms of scales that they do on a daily basis if you're using scales to follow them. And a similar improvement in terms of timing was seen with paroxetine 20 milligram in one study by the end of 3rd day. So be mindful. So one more clinical fact from this study: timeline is less compared to the antidepressant response, which is longer in terms of onset of response. So this was paroxetine. Let's go to that was fluoxetine. Let's go to paroxetine now. What dose of paroxetine is found effective for mood and physical symptoms of PMDD? Here, study done by Cohen, published in 2004. This was a multi-center, randomized, double-blind, placebo-controlled trial, and they used paroxetine CR formulation. They used 2 dosing here, 12.5 milligram and 25 milligram with placebo here. Here, patient received daily dosing, not the luteal phase, but daily dosing for up to 3 treatment cycles here. They used the VAS scale, Visual Analog Scale, for mood scores. What did they found? Well, both doses were found effective for mood symptoms, as expected, and improvement was seen within first treatment cycle. Onset of response was again faster, and only 25 milligram dose was found effective for physical symptom. You will notice that how lower doses for both fluoxetine and paroxetine failed to show statistical significance for physical symptoms of PMDD, like 10 milligram of fluoxetine and 12.5 of paroxetine CR, not significant for physical symptoms, whereas 25 milligram of paroxetine CR and 20 milligram of fluoxetine was effective significantly for physical symptoms of PMDD. Very important thing to be mindful of when you take history with patients in terms of the criteria that we talked initially. That will help you decide what dose to start your patients on. Somebody with predominantly physical symptoms, lower doses may not be a good option. Now, next question. We are still with paroxetine. How about intermittent dosing of paroxetine, luteal phase dosing of paroxetine? Was that found to be effective? Well, Steiner again published a study in 2005. This was again a multi-center, randomized, double-blind, placebo-controlled, 3-arm study. Used the same paroxetine CR 12.5 milligram, 25 milligram with placebo, used only during luteal phase dosing for females. Used the visual analog scales here to monitor them, and the study was positive. They found both doses to be effective and well tolerated in luteal phase dosing. So worth using luteal phase over daily dosing if possible, for both actually paroxetine and fluoxetine. Now moving to our third FDA approved medication, Sertraline here. What dose of Sertraline was found effective for PMDD symptoms? This will be answered by a study published by Yonkers in 1997. This was again a randomized, double-blind, placebo-controlled trial. They used a flexible dosing range from 50 to 150 milligram for Sertraline. And it was a daily dosing, not a luteal phase dosing. Scale was what we talked initially, DRSP, Daily Record of Severity of Problem Scale. What did they found? Well, the study was statistically significant in terms of showing improvement for all symptoms: depression, anger, irritability, and physical symptoms. So daily dosing of Sertraline is effective in that range. How about luteal phase dosing, intermittent dosing of Sertraline for PMDD symptoms? For this, there was another study published in 2002, and this study used a flexible dosing 50 to 100. Notice they used a less dosing range compared to the first study, which was 50 to 150. They used range between 50 to 100 only, and it was given only during luteal phase. They used the same scale, daily record of severity of problem, and this study, well, first of all, it was significant. It showed improvement in all symptoms. There were higher responders for Sertraline compared to placebo, and the quality of life and functioning outcomes were significantly improved with Sertraline dosing, and it was well tolerated in terms of side effects and discontinuation compared to placebo, much better. So these were the three FDA approved medications and the randomized placebo-controlled trials showing their effectiveness in a good range, well tolerated, with focus on both mood and physical symptoms of PTSD. What about another antidepressant, non-FDA approved medication? I was actually able to find only 2 medications looking at randomized trials, good studies. First was Escitalopram. Second was Venlafaxine. I will briefly touch on basics of these studies done in Escitalopram. Regarding the dose of Escitalopram, this study published in 2008, done by Erickson. They did randomized patient to dosing 10 milligram, 20 milligram, and placebo. This was a luteal phase dosing only for 3 months, 3 cycles. Scale, I was not able to find what scale they used, but results were very interesting to see. They found 20 milligram to be more effective than 10 milligram in terms of reducing symptoms. 20 milligram reduced symptoms of irritability, depressed mood, tension, and affective lability by 90%. These were that must symptom that we talked initially. What about physical symptoms? Well, they did some modest improvement in the breast tenderness, food craving, lack of energy, but it was not statistically significant or different from placebo. So I will say, based on this study, more effect on mood symptoms that we saw with escitalopram, and that too only at 20 milligram, not at 10 milligram dosing. And there was another study I thought I should include here. The question here is escitalopram efficacious if given only at the onset of symptom versus giving this during every luteal phase on a monthly basis? Well, study done by Freeman, published in 2005. They used the same dosing range, 10 to 20 milligram. One it was randomized to luteal phase dosing only, and other was to symptom onset dosing for 3 cycles. Scale was 17-item Penn Daily Symptom Report, DSR, and this is what they have. Well, they looked at the score reduction for this scale, premenstrual wise. So luteal phase dosing reduced symptoms by 57%, and symptom onset dosing had a 51% reduction in the score. But this is what's more clinically relevant I found, which is for a woman with more severe PMDD symptoms, they respond better to luteal phase dosing than to a symptom onset dosing strategy. And both were actually well tolerated in terms of side effect and discontinuation. So the main clinical information out of this study is if a woman have more severe symptoms, rather than using a symptom onset dosing strategy, prefer luteal phase dosing of this medication for escitalopram. Now, moving to our last antidepressant that I found in terms of study effectiveness is Venlafaxine. What dose of Venlafaxine was found effective in studies? Well, again, Freeman, very famous person in this studies on this topic, published a study in 2001. They used a dose range between 50 to 200. This was again a randomized double-blind placebo-controlled trial. And here, females were given daily dosing, not a luteal phase, for 4 menstrual cycles and used DSR as their main scale. And this is what they found. Well, Venlafaxine had 43% symptom reduction compared to placebo. And all symptoms, mood, function, pain, physical symptom had significant improvement. And more interesting thing, which was actually expected at this point, 80% of the symptom reduction were seen in first treatment cycle. So onset of response is definitely faster, as we have seen with other antidepressant studies before. And what dose was found effective in the studies? So they found a mean Venlafaxine dose ranging from 50 milligram per day during first treatment cycle to 130 milligram per day by fourth treatment cycle in this. So very positive study, good response, well-tolerated medication. The main side effect they found were nausea, insomnia, dizziness, but they all were mild and transient. So this study was daily dosing study. Is venlafaxine efficacious for luteal phase dosing, intermittent dosing in PMDD? Another famous person in this is Cohen. He published a study in 2004, used 75 to 112.5 milligram, 112.5 milligram dosing, and they used a luteal phase dosing, and this was started 14 days before anticipated onset of menses, and they were discontinued on second day of bleeding. They used these two scales, DRSP that we know already about, and PMTS, Premenstrual Tension Syndrome Questionnaire. Well, studies were effective. Significant improvement and well-tolerated study. I will not go into details of this study, otherwise we'll spend more than 2 hours on each medication. So this is what studies have shown in terms of antidepressant class. To summarize this is what we have found so far. Fluoxetine, paroxetine, and sertraline are FDA approved, but we have also studies on escitalopram and venlafaxine in terms of effectiveness. For fluoxetine, 20 milligram dosing is more effective than 10 milligram dosing in terms of effect on both mood and physical symptom. Same goes for paroxetine CR. 12.5 and 25 milligram have shown effectiveness. 25 milligram more effective for both mood and physical symptoms. Sertraline. Studies have shown effectiveness on both luteal phase and daily dosing, and dose has ranged from 50 to 100 milligram for luteal phase dosing and 50 to 150 milligram for daily dosing. For escitalopram, 20 milligram dosing is more efficacious than 10 milligram dosing. For venlafaxine, for both phases, it has shown effectiveness. Dose has ranged from 75 to 112.5 milligram for luteal phase and 50 to 200 for daily dosing. As you can see, for luteal phase, lower doses have shown effectiveness. For daily dosing, little higher doses have shown effectiveness. So my takeaway point from this review on antidepressant is, if possible, maybe begin with luteal phase dosing. Begin with the lowest effective dose. Begin with based on what symptom profile patient is showing in terms of mood symptom and physical symptoms. Also, I just want to add that I have not included another antidepressants, but I did found some studies. For example, for duloxetine, I found a single blind trial and case reports. They were effective, but my goal was to only include randomized controlled, placebo-controlled trials. I also found one study comparing fluoxetine and bupropion for PMDD symptom, and that study found fluoxetine to be superior. So I will say stick with these class. In my experience, I will stick with fluoxetine versus sertraline as my first line, then going to other options based on their response and toleration and medical comorbidities. So you have tried lifestyle modifications, antidepressant trials, and they are not that effective. What will you do next? Next few minutes, I will very quickly go into all the medication options that literature have shown us to be effective. The first one after antidepressant worth considering is trial of oral contraceptives. I found many studies with many combination of estrogen progestin combination, but most studies that I found effective was with this combination, DRSP slash 30EE. So DRSP is a drospirenone and EE stands for apanyl estradiol. And the dosing combination is 3 mg for DRSP and 30 microgram for EE, apanyl estradiol. Before I talk about them, let me briefly tell you what exactly they are and why are they used in PMDD. So DRSP is a spironolactone-like progestin. It has an anti-androgen effect, anti-mineralocorticoid activity, and studies have shown that spironolactone have some beneficial effect in premenstrual syndrome. I will talk about that in a few minutes. So I found many studies on this combination with PMDD. I will briefly touch the results of 3 studies that I found. They were done between 2001 and 2003. So first study on this combination and PMDD was done by Freeman again in 2001, and study was statistically significant, showed improvement in these 3 factors, 3 symptom improvement, and these 3 symptoms were appetite, acne, and food craving. The second study in 2003 showed improvement in general sense of well-being and improvement in the impairment in usual activities that happens with premenstrual symptoms. And the third study, again published in 2003 with this combination, showed improvement in physical symptoms of edema, bloating, and breast tenderness. So there are many other studies that I'm not including, but this is a good next step option, I will say, after antidepressants were tried. But again, I will say, once you are at this point, you have to collaborate with appropriate specialties, internal medicine, family medicine, OBGYN, as indicated. And after, let's say, person is not showing improvement with lifestyle modification, antidepressant trial, oral contraceptive trials, what options we have now? There are still few medication options available. But before we go into this, please be mindful. These medications now carry more side effect profile than what we have talked so far. So first one is GnRH agonist, gonadotropin releasing hormone agonist. The one that have shown effectiveness in some trial is called leuprolide. So leuprolide has shown to relieve symptoms of PMDD primarily by reducing the secretion of FSH and LH. Thereby it induces an ovulation and causes amenorrhea. And there were studies done where it was given at 3.75 milligram per month dosing for 3 months. It caused significant reduction in symptom, but as we just talked, the side effect is risk of inducing menopause. So you have to add estrogen and progestin with it. So the risk is, you start this medication, menopausal symptoms can come into picture, causing hot flashes, fatigue, irritability, osteopenia, cardiac problem. So it's not recommended for prolonged use if you go into that. And then once you induce this, you carry the risk of that bone loss and cardioprotection. So risk and benefit ratio discussion comes into picture here. So that's number 1 option, GnRH agonist, leuprolide. Once a month injection, once a month medication. After this, the other option is trial of synthetic androgens, which is danazol here. And the studies were done which shows given in 200 milligram twice daily dosing, very effective for premenstrual mastalgia. But again, be mindful of the side effect profile. There are many side effects including acne, increased facial hair, weight gain, and even depression with this medication. So that's number 2, danazol, synthetic androgens. Number 3 is diuretics. In that class, spironolactone is one that we were just talking with that combination recently. Spironolactone have shown effectiveness in some studies. In one study, it was given at 100 milligram per day during the luteal phase, and it results in significant improvement in negative symptoms and somatic symptoms. I will not go into details of these studies here just for the sake of time. I know this podcast has gone really long, more than I expected. So, let's end this session with the summary here. First, lifestyle modifications are recommended for treatment. Then you can go to antidepressant trials if needed, or to oral contraceptive. The combination of drospirenone / 30 ethinyl estradiol. But I will say go with antidepressant first. But here, collaborating with appropriate specialist will make more sense. If you have tried antidepressant, going to OC oral contraceptive option makes more sense. But if person has failed or still showing symptoms affecting their daily functioning, you can go into either of these 3 options: leuprolide, danazol, spironolactone. But side effect profile needs to be closely monitored for and discussed with patient before initiating these medications. So, thank you, friends. This was our podcast number 5. And I am Dr. Harvinder Singh. This is my email. Please contact me if you have any questions, concerns, things you agree with, don't agree with, anything you want to share with me. Love to hear from you all. This is the website, Psychiatry Education Forum, and this is our course link, Physician's Guide for Clinical Psychiatry. And as we discussed, this video podcast will be one of the chapter in this course. Please do consider subscribing our course if you like this podcast. I will continue to update this course with more chapters and video podcast. Thank you again. I will see you all in next podcast. Take care. Bye.